All right, friends. So we are going to study uh, extra reading in the trauma. So today's lecture is about the extra reading in the trauma. So we will discuss from the basic to how to read the X-ray properly. So let's begin. So our contents will be a general principle, bone and joint anatomy, bone and joint alignment, rule of two in trauma is very important, and the types of patterns, types or patterns of the fracture, locations of the fracture and incomplete fracture in the children. So approach to trauma extra reading and some exercise. Okay, let's begin. So general principle. So if we talk about the X-ray of the adult versus child, so basic difference is the growth rate. So presence of growth rate that suggests X-ray of the child. So what is growth rate and how it is seen on the X-ray is at the knee of the joint there is some translucent line at the near end of the bone that forms the joint. So we see the translucent line that is called growth rate. So from where the growth occurs. So near the joint ends, the bone part, this region is called as epiphysis, and the other end, this flared region is called metaphysis, and the tubular structure towards the shaft is called the diaphysis. So these are the parts of the bone, and in the children, on the X-ray of the children, we see the translucent line, and there is growth rate, but it is not visible or not seen in the adult X-ray. So this growth rate is fused. Only this portion is called metaphysis, and the remaining portion is called as a diaphysis. So this is a adult bone, and this one is a child bone. So this is X-ray of the knee. So this is the basic difference between the adult and the child X-ray. So what are the parts of the long bone again? So if we see on the child, so this the end of the bone towards the joint is called epiphysis. So translucent line growth plate. Next to the growth plate is metaphysis, and the tubular structure is a diaphysis. Whereas in the adult, only this metaphysis and diaphysis are seen. So diaphysis and those this tubular structure. So it consists of two parts, like peripherally the dense portion. If you see, this is white, right? So this is a dense portion, and it's called as cortex. So two cortices, and in the middle, we see the lesser dense area. So this is called the medulla. So the medulla and the cortex, these are the parts of the diaphysis. And the additional structures on the bones, we see that outgrowth that is not that is not forming a joint. So this outgrowth, metaphyseal outgrowth, which is not forming a joint, is called as apophysis. So in the proximal part of the tibia, proximal part of the femur and the humerus, we see some outgrowth, like in tibia, the tibial tuberosity, lesser trochanter or lesser tuberosity, greater trochanter or greater tuberosity. These are the apophysis. And the sesamoid bones are the bones, those with ossifies in the tendon. So patella is the biggest sesamoid bone, and there are other sesamoid bones too in the thumb and in the great toe. So in the thumb flexor, pollicis brevis, and in the great toe, flexor hallucis brevis tendon, and there is bone. Those are called as the sesamoid bones. Joint anatomy. So joint consists of two bones. This upper portion of the distal. If we consider this is knee joint, so two bones. There is distal part of the femur and the proximal part of the tibia. So these two bones, along with the, if we see, there is a gap between these two bones, so which consist of cartilage, and that cartilage is called as a hyaline cartilage in the joint. So another MCQ's question, and that is enclosed by some capsule on the either side, and those capsule are lined by the synovial cell, right? So the joint consists of two bones, hyaline cartilage, and the synovial cells. So these are the things that which forms the joint. And as I already said, we cannot see on the X-ray; it is invisible, and it is indirectly evaluated on the X-ray. So the space between the two bones that suggests the thickness of the cartilage. So bigger the thickness of the cartilage, and there we can see more space. So if there is a degeneration or damage in the cartilage, we can see that joint space is decreased. So this can be evaluated in the X-ray. So what happens in the osteoarthritis? Before that, if we see the normal joints, first let us consider the knee joint. So knee joint consists of two bones, distal femur and the proximal tibia, and the hyaline cartilage over here, and the capsule that is lined by the synovium. And if you see, there is some certain gap. This is the medial side, this is the lateral side. Why? Because the fibula is on the lateral side. So this is the lateral, and this is medial portion. And if you see, there is a gap between these bones. So distal femur and the proximal tibia. So some gap should be there. If the cartilage is damaged, for example, in the degenerative disease like osteoarthritis, so the gap will be decreased. If you see, we hardly see the gap between these two bones, distal femur and proximal tibia. And if you see, some outpouching is there. So these are osteophytes. So what are osteophytes? These are the modified the periosteal cells near the joint. So these are the osteophytes. And if you see this whitish line, this whitish line is a subchondral sclerosis. So this is a reactive changes. And after this damage of the cartilage, the fluid in the joint that will seepage inside this subchondral region, and it will form some cavity, and those are called cysts. And since this is formed below this cartilage region, so these are called as a subchondral cyst. So those are the findings of the osteoarthritis, like joint decrease in the joint space, osteophytes, subchondral sclerosis, and the subchondral cyst. So we can evaluate on the X-ray. So these are the findings of the osteoarthritis. Coming to the bone and joint alignment. So there should be alignment, the perfect alignment of the joint and bones. Suppose this is first metatarsal, this grade 2 proximal filings, and this is distal filings. So these are the well aligned, right? If you see, these are the well aligned bones and the joints. These are also well aligned. So if you see on this third metatarsal and the proximal filings of this third grade and the third two, we can see there is not well aligned. So these are abnormal separation. This is a complete separation of this joint, metatarsal, third metatarsal, and third toe, the proximal filings. So this is called as a dislocation. So complete separation, dislocation, and if it's not separated completely, that is partial separation, and that is called subluxation. So if we see, this is well aligned, yes, this is well aligned. Again, this one is well aligned, but it is not. So this is dislocation. So abnormal complete separation of the joint surface is known as dislocation. Subluxation is partial separation. Okay, this is the main difference between the dislocation and subluxation. Coming to the rule of trauma, rule of two in the trauma. So rule of two in the trauma are these 5 points. We have to go through this one. The rule of two in the trauma that ensure the accuracy, that prevent missed injuries and improve the diagnostic confidence. So we can confidently say that there is some abnormal changes or not, some dislocation or subluxation, or if there is a fracture or not. So it consists of two views, two sides, two occasions, two locations, and the two joints. So these are the rule of two in the trauma. So let's go one by one. First, two views. Generally, we perform the anterior posterior view, AP, and the lateral view. So always two views in we take always two views in trauma. One view may hide displacement or the fracture. That's why two views are important. So AP show medial lateral displacement, and the lateral shows anterior posterior displacement. What does that mean? So suppose if we consider this joint, this is a, so if we consider this one is a distal humerus, and this is a AP view. So if we consider this one is medial and this one is a lateral, so suppose there is a fracture, and on the basis of this, on comparison to the on respective of this proximal part, distal part, it will move either in direction, either in lateral direction or in the medial direction. So what is medial lateral displacement? Is the displacement or movement, this displacement of this distal portion compared to the proximal portion, where it is going. If it is going lateral direction, then that is called the lateral displacement. Or if it is going towards the medial direction, then that is called medial displacement. Likewise, so if we see on the lateral view, suppose there is a fracture, and this one is anterior and this one is a posterior. So this is the lateral view, this is the AP view, right? AP view, and this is a lateral view. On the lateral view, this fragment, either it will go towards the anterior direction or in the posterior direction. So if it is going towards the anterior, then we can say that this fracture is displaced towards the anterior, that is anterior displacement. And if this portion, on comparison to the proximal fragment, proximal segment, if it is going towards the posterior, then that is called the posterior displacement. So this is the important, and we can comment on the X-ray that whether it's going on the posterior or anterior. So on the basis of that, we can say anterior displacement and the posterior displacement. Sometimes it is not completely displaced, but from certain angle like this. Okay, so if this is anterior, this is posterior on the lateral view. So again, this is X-ray, that picture of lateral view. If this is anterior, if this is posterior, then the apex, whether it is that focus that is pointed towards, like if the apex is pointed towards the anterior, then we can say that is anterior angulation. Or sometimes like this, suppose this is anterior, this is posterior, the apex is over here. So whether the apex of this fracture is angulated towards the anterior or posterior, on the basis of that, we can say this is anterior angulated or posterior angulated. So this one is anterior angulation, this one is a posterior angulation. So these are the two things that we can say on the two views. So what are the importance of the views? Let's see with the help of this picture. So if we see this picture, this guy is it assume that we can assume that this person is sitting on the restroom and having some stops on his mobile phone, and this boy is having his good time with his girlfriend, but the scenario is different. If you see on the other views, this boy is this guy is having taking a rest on this chair and doing something on the phone, and previously you say that he was having some good time with his girlfriend. Yeah, he's having good time, but it's not his girlfriend. You can see this is his pet, like his dog, his friend, right? So this is the importance of the two views on the trauma. Likewise, if we see on the X-ray, this is the X-ray of the ankle, AP view, and the lateral views. And if we see on the X-ray of the AP view, we hardly see on any abnormalities. And if we see on the lateral view, we can see there is a high oblique fracture. So this is the importance of two views. On the lateral view, it's clear, but it's not clear on the AP view. So that is the importance of two views. Two sides. So there are two things that the two sides that God has given to us so that we can compare to normal side to the abnormal side, right? So if the trauma occurs on the right side, then we can compare that on the left side. So especially if when we confused with the fractures or some abnormalities, especially on the children. So suppose this is the example, like if we see on this X-ray, this is the X-ray of the right side, and some abnormalities we can assume on the medial epicondyle because there is some translucent line. But the translucent line, it suggests a growth plate, and it might be normal. But when we take X-ray on the contralateral side, that is normal side, we can see a translucent line over here also, but the gap, the translucent line on the right side is more than the left side. So we can confidently say that this is a fracture. So this is the importance of two sides. Similarly, in this picture, we can see on the right side of this hip. So there is a one translucent line on the neck of femur, right? And we cannot comment on the basis of this X-ray if we see only on the right side. But if we see on the left side, so there is no any translucent line. So this is not normal compared to this one, right side, compared to this left side. So there is a fracture on the right side, neck of femur. So this is the importance of the two sides, two views, and the two sides is over. So two occasions, sometimes. So specifically that if we talk the example, then scaphoid fracture. So it's very, if you think like a clinical suspicion of the scaphoid fracture, like anatomical Isnaphox tenderness or the scaphoid, that ship test is positive, then it might not be visible that there is a fracture on the scaphoid region, that the scaphoid bone. But when we do X-ray on the other setting, like after 1 or 2 weeks, then there might be the visibility of fracture. So if we see on this first X-ray, earlier at the time of injury, there is no any fracture, right? If you see, there is no fracture. But when we repeat the X-ray after 2 weeks, there is one translucent line. So this is a fracture. So this is the importance of two occasions, two views, right? Two sides and the two occasions. Three, the rule of two are gone. Now fourth one, the location. So specifically, if we talk, then the fall injury, history of the fall injury and impact on the heel region, and there's this guy sustained the calcaneal fracture on the bilateral side. So this is a calcaneal fracture on the left side. This is another fracture on the right side. So on this type of injury, the associated injury is the spine fracture. So we have to suspect some injuries, the spine injuries or the fracture on the spine. And if we see the fracture, that X-ray of this portion, so all the spines are okay. So this one, this is also okay, and this is also okay. So if we see, all are okay except this one. You see, there is a burst fracture on this spine. So on the calcaneal fracture, the associated injury is a spine fracture. So two locations are important. Some associated fracture will be there. The last one, the last one is two joints, one joint above and one joint below the injuries. So it must include both the joints. generally the fractures called as a Montesia fracture or Gallagher fracture, these fractures are easily missed on the that X-ray if we perform only the region, the injury region. So we have to perform the X-ray of the one joint above and one joint below. So if we see the example of this one, if you see example, this is a X-ray of the X-ray elbow lateral view. We can see there is a dislocation of this radial head from the elbow joint, right? So if we don't do a X-ray of the joint below this one is a wrist joint, right? So to include the wrist joint, whole forearm should be scanned. So when forearm is scanned, you can see there is a fracture on the proximal portion of the ulna associated with the radial head anterior dislocation. So this proximal shaft of ulna fracture along with radial head dislocation, this is called as a Montesia fracture dislocation. So these type of injury are easily missed if we perform only the X-ray of the region that is injured. So we have to include the one joint above and the one joint below. Similarly, so if there is a femoral fracture, we have to include the X-ray of the hip, and we have to include the X-ray of the knee joint also. So these are the importance of the two joints. So all the rule of two in the trauma are over. I hope you got those points. So those I wanted to share with you. Next one is image quality. Depends on the proper positioning. It might be not possible because of some pain or uncooperative patients are one of the risk factor that the image quality will be not good. So we have to use all available image only if it is needed, then we have to repeat it. So proper exposure is another issue that we are not getting properly for the this proper image or X-ray. So example is like in this picture A, this is an underexposed X-ray, and picture B is overexposed X-ray, right? So to get the proper X-ray, these the parameters should be adjusted. So kVps and this MES, the milliampere second. So this should be adjusted to get the proper image quality, so that we don't miss the pathology. So this is picture A is underexposed, this is overexposed, and the normal mean X-ray is like this. So we have to get this picture to interpret the correct findings. Next one is artifact. So something seen on the X-ray, not naturally present artifact, like some technical issues, orthopedic surgery, the previous implants, these will produce artifact. Some foreign bodies, they will produce artifact. Clothing, metals, objects, or monitor that ECG leads sometimes, these will produce artifact. Like this female is having this some metallic object on her bra, and this will produce an artifact, and we can easily misinterpret this one. So be careful about the artifact. Okay, let's go for the types of fracture, the basis of pattern. So classically, five classic fracture patterns are there. One is transverse, next one is oblique, spiral, comminuted, and segmental. So we will discuss one by one. Transverse fracture. So the fracture is perpendicular to the long axis of the bone. So this is not perfect definition, but the angle should be less than 30 degree, right? Angle should be less than 30 degree to the perpendicular of the bone. So if we create this long axis, so suppose this is the long axis of the bone, and we have to make one perpendicular line. And on this perpendicular line, the fracture will occur. And the direction of this fracture to the perpendicular of the long axis. So in between this one, we have to draw angle. So if it is less than 30 degree, then that is fracture. That fracture is called transverse fracture. So if it is more than 30 degree, then what is this called? So this is called oblique fracture, right? So this is the definition. So transverse fracture, this angle between the fracture and the perpendicular of the long axis is called is less than 30 degree. So it's caused by usually by the direct blow or the bending force. So this is the mechanism of the formation of the transverse fracture. Next one is oblique fracture. So if you see the angle is more than 30 degree in this condition, so this is called oblique fracture. So more than 30 degree oblique fracture. So it's caused by axial loading. So this is the mechanism, the axial loading. The next one is a spiral fracture. So fracture, those are seen on the two planes are called as a fractures. Two planes are called as the spiral fracture. So mechanism is generally the twisting injury. If we see on this fracture, so one is fracture line is this, next fracture line is this one. So this is called a spiral fracture. Comminuted fractures, if we see the multiple fragments more than equal to 2 segments, that is called as a comminuted fracture. That one segment is over here, next one is here, another fracture segment. And if you see there is that split or that extension up to this distal portion of this femur, and this fragments causes this comminution, causes this fracture as a comminuted fracture. It's high energy. This type of fracture is seen on the high energy trauma. The last one is a segmental fracture. So there will be multiple fragments, but isolated one whole fragment is present over here. So this is called as a segmental fracture. So two separate fracture line creating an isolated bone fragment is called as a segmental fracture. So two separate fragment, this one, that is causing an isolated fragment that is called a segment that isolate and that a segmental fracture. So it's a highly unstable type of fracture. So I hope this clears the patterns of the fracture, all the fracture, transverse, oblique, spiral, comminuted, and segmental fractures. So these are the basic patterns of the fractures on the X-ray we can comment on. Next one is a location of the fracture. So adult bone has two parts, the metaphysis and diaphysis. So based on this, where fracture is present, like or on the metaphyseal region or the diaphyseal region. So based on that, on the X-ray, we can comment. And next one is a child and the long bone. It has epiphysis, growth plate, metaphysis, and diaphysis. So generally, growth plate injury is common on the children. So we can comment on the fracture or injury present on the growth plate. So it is classified on the basis of the Salter-Harris classification. So 5 types, 1 to 5 types are present. So increase in the grade of the fracture, the increase in the severity of fracture. Most common is the type 2 Salter-Harris fracture. So this is another MCQs. And diaphysis is subdivided into 3 portion, whether in the proximal 1/3, middle 1/3, or the distal 1/3. So it is used for the precise localization. So we will practice on the coming slide on the interpretation of the X-ray, right? Coming to the incomplete fracture. So 3 types of incomplete fractures are there. One is plastic bending. Next one is torus fracture. And the last one is a grain stroke fracture. So these are the injury pattern, that is incomplete fracture in the children. So incomplete fracture with the permanent bending is called as a plastic bending. So if you see this forearm fracture, is commonly seen in the forearm. So forearm, I have kept the example of this forearm plastic bending. It should be straight, right? But it has some bowing over here. So injury, that force causes some deformation over here. So bone has some elastic property. When we pause or when we stop the force up to that before it's the limit of elasticity, then it will go into its original position. But the time will come beyond its elasticity. The force beyond its elasticity that will lead to the permanent bending. That is called as a plastic deformity. So it has to be corrected. And next incomplete fracture is a torus fracture. So on the this ancient that building, that pillars has some sort of soiling over the distal and the proximal portion of the pillar. So this is called the torus, and the axial loading and the children that will produce some that soiling over the metaphyseal region. So there is that popping of the cortex due to the axial compression that will lead to the some soiling, and that is called as a torus fracture in the children. Generally, it is seen on the metaphysis of the radius bone. Okay. Coming to the green stick fracture, so that bending force, what will happen on the if we see the green stick on the twig of this green stick, when we apply the force towards the side where we apply the force, it will some buckling will be there, or it will generally will be intact, but the other side it will break. So one side break and the another side is intact. So this is called as a green stick fracture. So this side is called tensile side, and this side is called as compressive side. Compressive side will be intact, and tensile surface will be broken. So one cortex intact and other cortex broken. This is called as a green stick fracture. We can see this this forearm X-ray. So this is the impact, that region of the impact, and if you see towards the region, the cortex is intact, but the opposite side cortex is broken. So this is called as a green stick fracture. So classic pediatric injury pattern. Coming to the approach, the 6 keys to read the trauma X-ray, and generally we have to start from the bone, and we go towards the soft tissue. So some people, they will come from the soft tissue to the bone, but it's easy and more reliable when we go from the bone towards the soft tissue. Image details. So we have to see about the age. Why age? Because we have to comment that a person is skeletally mature or skeletally immature. So if age is not given, then we have to see that person's X-ray, the person is a child or adult. So if growth plate is present, then that is a child X-ray. If growth plate is not present, then that X-ray belongs to the adult one, right? So we have to see the sex of the patient, side of the limb, view, and the date of the X-ray. So these are the image details that we have to see on the X-ray. So when describing the trauma X-ray, always includes 6 points. So what are those 6 points? So we have already gone through this one. So X-ray, which part, like elbow or wrist, like this, view, AP, or lateral view, these type of details that we have to go. And the type of fracture, morphological classification, we have gone through this one. Transverse, oblique, right, comminuted, segmental, like this. So we have to explain about the type of fracture. Next one is location, the anatomical region. So proximal 1/3, middle 1/3, or the distal 1/3. Side, right or left. Bone involved, which bone, radius or ulna, or humerus, or tibia or fibula, like this. And the displacement, we already have discussed about this one. So we will see one by one. X-ray of which region, that we have to comment on that one. The identify the region of the center of the film. So the focused portion is the elbow. So this X-ray is a X-ray AP view of the elbow. Okay. So this one is a lateral view. So that is the X-ray part. That central film, that is the X-ray part, the elbow, this AP view and the lateral view. Usually it's given AP and lateral, and if extra joints are included, we have to comment on that. Like this focused portion is elbow, but we can see the forearm bones, right? And along with the wrist bone, wrist joint. So we have to comment on that. So what are the focused part and what are other that mention the included joints on the X-ray. So again, the types of fractures, the fracture morphology, we have already gone through this one. The accurate identification is essential. So this one is a transverse fracture, oblique fracture, a spiral fracture. Another fracture line should be over here to see to say the fracture is spiral. Comminuted, multiple segments are present. Segmental, isolated, one segment along with the proximal and distal segment. So these are called as patterns of the fracture morphology. So we've gone through this already. So mention if the fracture is on the epiphyses, metaphyses, or diaphyses, or proximal, middle, or the distal 1/3. So we have to comment on that. Coming to determining the side. So look for L or R. L for left or R for mark. R for right, right? And if no label is given, then determine using anatomical position. So anatomical position, we know from our medical school, we place the X-ray on the anatomical position, and on the basis of that anatomical position, we can determine the side. So it's only possible when AP X-ray is given, not in the lateral view. So if only lateral view, then side cannot be determined, and we have to mention this one. Okay, so this one is if you say this one is the side is not given, L or R is not written, on the basis of lateral X-ray, we cannot say that this is right or left, but we can say that on the X-ray, if we put this X-ray on the anatomical position, then it becomes the X-ray of the right side, right? So right side X-ray. So this one, again, if this is right side and this is a left side, so medial malleolus is over here and lateral malleolus is this one. Fibula is on the lateral side. So this one is middle side, this one is a lateral side. So on the basis of this one, so we can say this is the X-ray of the left side. But on the basis of this lateral view of X-ray, this we cannot comment that whether this is the right side or left side. So we have to be aware of this one. Identify the bone. So it should be accurate. And the easiest steps, right? There are total 206 on the human body and more than 206 on the newborns as well. And we have to mention the bone, which bone is fractured. Okay, displacement. Again, this on the AP view, the displacement and angulation, the medial lateral displacement and medial lateral angulation. So we have already discussed about it. On the lateral view, we can say displacement, the anterior posterior, angulation, and the anterior posterior. So we go through this example. So understand the displacement based on the distal fragment on comparison to the on respect to proximal, right? So this is the definition of displacement. So if you see, this is AP view of the elbow. If you see, there is a distal fragment is over here and the proximal fragment is over here. So on comparison to in respect to proximal fragment, distal fragment is going towards in which direction? So this is a middle one, this is a lateral one. How? Because the radius is on the lateral side. So this is a radius and this one is a ulna. So ulna is on the medial side and the radius on the lateral side. So distal portion is going towards the middle side compared to the proximal fragment. This is going towards the distal, that medial side. So medial displacement, right? And on the AP view, where it is going, sorry, lateral view, where it is going. So obviously this forearm means that is anterior, and this is a posterior, right? And on comparison to this proximal fragment, this is the distal fragment, and distal fragment is going towards the anterior direction or posterior direction, where it is going. So this is anterior, so it is going posterior on compared to the proximal fragment. So this one is a posterior displacement. Okay, so combinedly we can say this is a posterior medial displacement. So that's why I have written over here. This is a posterior medial displacement. Coming to this one, this picture, this X-ray. So if you see, there is a this is a AP view and this is a lateral view. AP view, on AP view, we hardly see some displacement, though there is some displacement. And this is a fibula, and fibula is on lateral side, and this one is obviously medial side. This is lateral side. That means it's going to the medial, right? But more than displacement, we can see some angulation is over here. So this one is angulation. Okay, this one is angulation. So where it is angulated, anterior or posterior? If you see, this is the patella, right? Patella is on the anterior aspect. Okay, that means this is the posterior aspect. So apex is forming towards the anterior direction, right? This is apex. Okay, so that means this is the anterior angulation. So that's why we have comment this fracture distal third of the right femur is the anterior angulation. So this is the displacement and angulation that we have to comment on the X-ray reading. Okay, keep in mind these 8 things. On the basis of these 8 things, we can comment any fractures or any X-ray. Okay, we can read any X-ray. So first 4, you make a once statement, and the next 4, you make a next statement. So 2 statement, we can read the X-ray. So what are those? Side, part, view, maturity, skeletal mature or immature, fracture morphology, which bone, in which part, in which location, either in the proximal, middle, or distal, right? So angulation, displacement. On the basis of these 8 features or 8 points, we can comment on the X-ray. Okay, let's practice the exercise. So I have kept this one so that it will be easy to see and comment on the X-ray. So X-ray, this is X-ray, right? So this is AP view, this is a lateral view. Centrally, which region is exposed over here? Obviously, this is a forearm bone. This is AP view, this is lateral view. Forearm bone, wrist is given, hands are given, and I cannot see any elbows, right? And some angulation is over here. Rather than displacement, you can see there is a angulation, and some transverse fracture is present over here, like this. So including these points, so we can make a statement like this is the X-ray of the left forearm. Okay, left forearm, L is given. Okay, side is left side, and AP and the lateral view. Okay, side, left side. Okay, forearm. Okay, view AP and the lateral of a skeletally immature individual. Why? We can see the radiolucent line over here. So this is a growth plate. That's why we have mentioned the skeletally immature individual, and we make a twist up. So 1, 2, 3, 4 parts are gone. Okay, growth plate. On the basis of this one, so we make a one statement over here. Next one is the fracture morphology. Let's see. So if we consider this one axis and the perpendicular, then it's hardly making 10 to 15 degree. Okay, that's why this is a transverse fracture. The fracture morphology, transverse, okay? Bone, which bone? Both radius and ulnar fracture. So radius and ulnar bone, radius and ulnar, where it is fracture. This is a proximal 1/3, okay? Proximal 1/3. This is a middle 1/3, and this portion is a distal 1/3. So that's why I've written over here distal third with the angulation is there, right? Angulation. So anterior angulation or posterior angulation. So where it is anterior posterior. So for that, the easiest way that I remember on that way that extensor surface, we have a less muscle compared to the volar surface. So more muscle, that means more soft tissue, and the less muscle means less soft tissue. So if we see on this X-ray, soft tissue over here is less compared to soft tissue over here. So this is the anterior, okay? This is the posterior. So that means on the anatomical position, if we kept like this become anterior and this become posterior. That is, this is ventral surface, this is a dorsal surface. So if we see angulation, the apex is towards the volar, that is anterior. Okay, so that's why the angulation is anterior angulation on the both the radius and ulnar. So these are the points that easiest way that we can remember this one, and we can comment on the X-ray. So you can practice like this one. Okay, let's read this one. So I have put this 8 points, first 4, then the second 4, like this. So what is the X-ray of this one? So wrist is given over here, right? So left or right. So on the basis of the this AP view, this is the X-ray of the left side. So left wrist, this one is AP and this one is lateral, right? So left wrist, AP and lateral view, that is skeletally mature or immature. So there is no growth plate. So that's why this is a skeletally mature X-ray individual. So we make one statement up to here. Side, left side, part, wrist, okay? Wrist, view, AP and lateral, and maturity. Adult, that is skeletally mature, okay? So one statement is gone. So if we see there is a fracture, so this is a fracture, like this is a fracture. So if we make this perpendicular, then it's hardly making the angle of 10 5 to 10 degree, that is less than 30. Less than 30 means a transverse fracture. So we comment this as there is a transverse fracture. Where? At the distal third of the radius, with the distal third of the radius. So this is the radius bone, okay? This is ulna. So distal 1/3 of the radius, and there is a fracture on the distal 1/3 of the radius. The distal radial ulnar joint dislocation. If you see, there is some separation of the joint, distal radius and ulna separated. So ulna is over here, radius is over here. That means obviously there is a dislocation. So there is a transverse fracture at the distal third of the radius with the distal radial ulnar joint dislocation. And the next statement is there is a posterior medial displacement of the fracture. So if we talk about the displacement, so what is here? Like ulnar side is the, if we keep this like on this anatomical position, then the ulna is on the medial side and the radius on the lateral side. That means ulna is on the medial side, this one is on the lateral side. So on the mediolateral displacement on the AP view, on compared to the proximal fragment, this distal fragment is going towards the medial side, right? That's why it's going towards the medial. But in the lateral view, this distal fragment is going posterior, and compared to this proximal fragment. So what is total displacement? Like this is going posterior, and also in the medial direction. So there is a posterior medial displacement of the fragment. So this fracture, that is distal shaft of the radius, along with dislocation of the distal radial nerve joint, is called as a Galeazzi fracture dislocation. So this is important. So if you mention up to this one, the external will be happy. Okay. So like this, we can comment on the X-ray. So let's do an exercise. Okay, include these 4 points for the first statement, next one for the next 4 for the next statement. So let's comment on this one. So what is this X-ray? So X-ray of the leg. Okay, so right or left. So on the basis of this AP view, this X-ray is a X-ray of the left side, right? So this is medial malleolus, this is lateral malleolus, this is lateral side, this is medial side. So this is X-ray left, X-ray leg, okay? X-ray leg, AP and the lateral view, X-ray leg along with what? Ankle. So there is obvious joint is present. Obviously, we can comment on the ankle joint also. So X-ray left side, left part, leg, right? View AP and the lateral maturity. So can you see any bone with that growth plate? No, we cannot see any translucent line over here. So all are fused. So skeletally individual. So this is a X-ray X-ray left leg along with the ankle, AP and lateral view, okay, of the skeletally mature individual. One line is over, full stop. Then we can see there is a multiple fragments, comminuted fracture. Okay, so these are the multiple fragments. That's why it is comminuted fracture. So fracture morphology, comminuted fracture, bone. So this is a tibia, fibula, both are shown, but the fracture part is only tibia, right? That's why we can comment on the fracture is on the tibia only. So location is mid third, okay, mid third, mid 1/3, okay, and angulation. I hardly see any displacement or angulation over this one, but there is displacement in which direction? So this is the distal fragment, this is the proximal fragment. Fibula is on the lateral side. I already told about it. So this one is a lateral side, this is a medial side, where it is going. So it's going on towards the lateral direction. This distal fragment is going towards the lateral direction and compared to the proximal fragment. So there is some displacement, but we cannot comment obviously over here. So obviously that obvious displacement is a lateral displacement. So we can comment on the basis of this one. So let's see our comment. So this is a X-ray left leg, okay, AP and lateral view, including ankle of the skeletally mature individual. So we are right up to here, okay. There is a comminuted fracture, right? Comminuted fracture at the middle third, right? So we have mentioned about this one, middle 1/3, middle third of the tibia with which displacement? Okay, yes, you're right. We are right, lateral displacement. Okay, so in this way we can we can comment on the X-ray. We can read the X-ray like this only. So let's read this one, exercise 4. So this is a X-ray. Which side, right side or left side? Obviously on the anatomical position, if you keep like this, then this is X-ray of the right side. Okay, right side part. This is a shoulder X-ray, right? Shoulder plus arm. View, AP or lateral, or both. This is only AP. Maturity, skeletally immature. Why? Because we can see the growth plate over here. This is growth plate. So this is a growth plate, and up to this one we can comment like this. This is a X-ray of the right shoulder, including the arm, AP view, okay, of the skeletal immature individual. So one statement is over, and the next point, fracture morphology. If you see, this is another transverse or oblique. It looks like a oblique also transverse, but doesn't matter. It looks, we comment is it as a transverse fracture. Okay, transverse fracture. Bone is humerus bone, and location proximal 1/3. Okay, proximal 1/3, and angulation. So this is the medial side. Obviously, towards the center is the medial. Away from the center is the lateral. So this is the medial side, and this one is the lateral side. The angulation is on the lateral side. So let's see the comment. So X-ray, right shoulder, APV, skeletal immature individual. Yeah, there is a transverse fracture of the humerus at the proximal third with a lateral angulation. In this way, we can read the X-ray. Okay, so some exercises are there. So you can pause the video over here, and you practice on your own, and the answer will be like this only. Okay, X-ray left ankle, AV lateral view of skeletal immature individual. There is a transverse fracture of the middle malleolus also. There is a spiral fracture of the fibula at the distal third with the posterior lateral displacement. This is a fracture of the, there is a fracture of also the posterior malleolus. Like this, you can comment on the X-ray. Okay, like this, you pause the video, and you practice it, and you see the answer. So this is the answer, right? Exercise 7, again, do same thing. You pause the video, and you write your answer on your copy, or you can recall in your mind, and you can check the answer. So these are the answer. Exercise 8. So this is a Monteiro fracture dislocation, right? So you can comment on the X-ray like this. And exercise 9, this is a Colles fracture. But before you say the Colles fracture, you have to read the X-ray properly with these 8 points. So this, in this way, you can write. So I made this presentation, that lecture of this for you from this book. It's a very easy and a handy book by Professor Dr. Amit Joshi. And thank you for your patience. So all the best for your upcoming exams or your clinical practice. Thank you.